Hi guys, welcome to your new prosthodontic lecture. So today we will look at talking about occlusion. Okay, so basically we would concentrate on occlusion for complete dentures. You have occlusions for removed partial dentures and fixed partial dentures as well, but there's a slight difference with occlusion with complete dentures and occlusion for removed partial dentures and fixed partial dentures. So, in this lecture, we will learn about we will learn about what is the difference between the natural and artificial occlusion. List the 5 objectives of balanced occlusion, so you would know what is Hanau's squint and the factors of balanced occlusion. Recall the factors affecting balanced occlusion. Discuss and recognize the importance of compensatory curves. Basically, you would have learned about compensatory curves and about a little bit about balanced occlusion when you do your teeth arrangement. So we will know why compensatory curves are important, so that you have to give it in complete dentures, and then explain lingualized occlusion, a different type of occlusion which you would see and probably use in some cases. Now, moving on to your differences between natural and artificial teeth. Now, what I would like to say is here is natural dentition works totally different from your artificial dentition. So let's compare what it is. So when you see a natural dentition, you will see as a single tooth. So each tooth is in its own PDL, that is periodontal ligament. So when you actually put a pressure on a single tooth, this single tooth acts as one unit, or it just acts independently. So the pressure is bared, or any kind of occlusal force on this single tooth is bared by that tooth individually. And when you look at malocclusions, they do not affect immediately. On the long run, there might be some effects with malocclusions, but they do not give a severe effect. And when you have occlusal forces on the single tooth, they are well bared by the single tooth or multiple tooth. And when there are non-vertical forces, that is apart from your occlusal forces, which is also well tolerated by your teeth. And incising does not affect posteriors. That means to say, in this, when you actually bite with your incisors, your posteriors do not have any effect on them, or do not come into any kind of functions, like when you bite on a biscuit, when you break a biscuit with your anterior teeth. So the posteriors are not actually working, but incisors actually give you an incising effect and bear the occlusal forces by themselves. And there is no bilateral balance. That means when you bite on one side, the other side is actually not in bite. Let's say, if you could try it out, if you bite on your canines, or you glide your teeth on the canines, you see that just the canine of the upper and the lower come in contact, but the other teeth are not coming in contact. So there is no bilateral occlusion or balance in the occlusion. So not the left side of the canine comes into contact when there is a bite on the right side of the canine. And tactile sensitivity, which is very important, which helps the patient to chew better and also feels better. So natural dentition is always an advantage, and it's always good. That's why we always talk about preservation and a conservative approach than going on full on removal and stuff. So always preserving your natural teeth is the best than giving an artificial dentition. So moving on to artificial dentition, now we see in an artificial dentition, we talk about just the complete denture. So when we're talking about just the complete denture, we see complete denture as one whole unit. So that means to say that each individual teeth what you have placed in the complete denture is lying on the denture base. This in turn lies on the mucosa. So when you bite or you put a pressure on an individual teeth, the entire base takes the pressure and the entire load is going onto the mucosa. So the entire denture acts as one unit, even though there is pressure on a single tooth. The teeth move as a unit. As I spoke, yes, they move as a unit, and malocclusions definitely affect immediately. If there is any kind of malocclusion in the artificial dentition, they would affect. Non-vertical forces, that is apart from your occlusal forces, are they affect on the teeth and can cause traumatic effect on the mucosa. Incising effects, all teeth attached to the base. So when you say that when you bite from the anteriors, you incise any of the biscuit from the anteriors, there is some kind of load happening onto the posteriors as well, because it's on a complete denture base, which is acting effectively as one unit. And bilateral balance is mandatory, is always desired because of the stability, meaning to say if you bite on one side and if you see that there is no bite on the non-working side, you know that the stability of the denture tends to go off. That is, it tends to wobble. So what we actually try to do in complete dentures is, even if there is a bite on one side, we try to make sure the other non-working side is also in contact, or the cusps are in contact, so that it gives a stability for the denture. And then decrease tactile senses, in meaning there is absolutely no tactile sense. The chewing is not well appreciated by the patient when it is in the artificial teeth. The taste is not well appreciated because he's not able to know how he chews. At the same time, he's not breaking the food efficiently as your natural dentition, so the taste is not as great as what you see in your artificial occlusion. So now this is the difference what you see. All you got to remember is artificial occlusion or dentition is all together as one unit. All your incisors and your posteriors, anteriors are acting as one unit, but as in natural dentition, each tooth acts by itself. Now, now coming to maximal intercuspal position. So as you see in the figure, you can see all the cusps are well seated inside the groove. So when the mandibular cusps are well seated inside the grooves of the maxilla, it is called maximal intercuspation. The complete intercuspation of the opposing teeth independent of condylar position, sometimes referred as best fit of the teeth regardless of condylar position. So that means to say the way you chew. When you bite completely, that is maximum intercuspation. In this bite, when you completely bite or chew, what is happening is you don't know whether the condyle is in the anterior superior position in the clinoid fossa. So it might be, it might not be. In most of the cases with natural dentition, your centric relation is not equal to maximal intercuspal position. So what happens is, when the mandible is in centric relation, as you close down, it is in the anterior superior position, but when it comes in contact, there might be a subtle contact and the mandible might move a little front or back, okay, to get into the maximum intercuspal position. So when this is happening, that means to say maximal intercuspal position is not equal to centric relation. This is seen only in natural dentition. Okay, remember that this is only in natural dentition. So now when we look in complete denture, is maximal intercuspal position in centric relation are equal? Yes, because when you record your horizontal relation, you are actually recording what? Centric relation, right? So you record the centric relation, you seal the wax rims, occlusal wax rims in the centric relation, you take it out of the patient's mouth, you articulate it and you arrange the teeth. So eventually you have recorded the centric relation and put that in the articulator and you're arranging the tooth. When you arrange the teeth, you are going to give maximum intercuspation. That is, all the cusps are going to be in the groove. So eventually what has happened? You have arranged the teeth in such a way that it is in centric relation. So in complete denture, most of the time, your maximal intercuspal position is equivalent to centric relation. Okay, so centric occlusion is nothing but the occlusion what you have created. So you have recorded the centric relation and you made an bite which is equivalent, or you made the maximal intercuspal position equivalent to centric relation. So when you have done that, that occlusion is called as centric occlusion. So the occlusion of opposing teeth when the mandible is in centric relation, this may or may not coincide with maximal intercuspation. Okay, so next is your Christensen's phenomena. So Christensen's phenomena is important in balanced occlusion. So what is Christensen's phenomena? So when you bite completely, so when you are in maximum intercuspal position, you try to glide the mandible forward. So when you're gliding the mandible forward, you see that the labial surface of the lower mandible, the labial surface of the incisors of the mandible glides over the palatal surface of the upper anteriors. So when it glides over, you see that there is a space which opens at the back. The posteriors do not come into contact. So when you're doing this, So when you're doing this, the space what you see at the posterior is Christensen's phenomena. The creation of space between the posterior teeth bilaterally during protrusion or on the balancing side during lateral excrusion is Christensen's phenomena. Christensen's phenomena is only seen in natural dentition. It should not be seen in complete denture. If you make this Christensen's phenomena in complete denture, then the stability of the denture is lost. The retention of the denture is absolutely lost. The dentures in the patient mouth wobbles. So this should be absent in complete denture or complete denture occlusion. Okay. So coming to occlusion in complete dentures, we have certain general concepts which talk about uh, complete denture occlusions. These concepts are not exactly to be followed. They are just the theoretical knowledge which was given by few of the founders of these concepts. So first one is the spherical concept. So according to this concept, the anterior, posterior and the mesodistal inclines of the artificial teeth should be arranged in harmony with the spherical surface. So what is the spherical surface? There is a sphere of 8 inches with its center in the glabella. When you make a circle, okay, a sphere which is its center from the glabella, when you make it from 8 inches, all the teeth are arranged in that sphere itself. So this is spherical concept. Now coming to organic concept is uh, this one is the concept. The teeth are altered as the cusps are altered to suit the patient. Means to say there is certain alterations which are done on the teeth which will or which will suit the occlusion or suit the patient. Now what are we actually talking? What is this alterations you're doing on the teeth? So what you do is you determine the condyle gliding. So when you determine the condyle gliding, according to the condyle glides, you alter the ridges and the grooves of the teeth. So when the condyle glides, there is no interference between the occlusion. That is, there is no kind of sudden contact in the teeth. So it is free of interferences, and also the mandibular movement is determined by the factors like the height, cusp height, fossa, depth of the fissure, and concavity of the lingual surfaces. So what does this mean to say is uh, that the teeth are in harmony with the muscles and the joints during function. That is, the teeth are not determining the occlusion, but the condyle is actually determining the occlusion. This is one of the organic concepts which did come up. It is actually not being followed in present prosthodontic scenario, neither your spherical concept or your organic concept. Then neutrocentric concept, which is one of the concepts of occlusion. This concept says that the plane of occlusion should be flat and parallel to the residual ridge, which is also not followed nowadays. The plane of occlusion though is considered at one level and is considered at flat, but there is a curvature in the plane of occlusion when you arrange your teeth. That is where your curve of Spee and your curve of your compensatory curves come in. Okay. Now types of occlusion. Sliding occlusion. Sliding occlusion is nothing but when you protrude your mandible, you see the sliding which happens in the teeth slowly glides out. That is your sliding occlusion. That's the gliding which is taking while there is an occlusion. Centric occlusion we spoke about. Eccentric occlusion is nothing but any kind of occlusion where the mandible is not in centric. If the mandible is not in centric, any kind of occlusion taking place is called as eccentric occlusion. Okay, and balanced occlusion and balanced sliding occlusion we will talk a little later, because we would talk much more about what is balanced occlusion. Okay, so next coming to balanced occlusion. What is this balanced occlusion? Okay, balanced occlusion is defined as bilateral simultaneous anterior and posterior occlusal contact of the teeth in centric and eccentric positions. So when you take a denture, okay, when you ask the patient to, you have arranged all the teeth and then you ask the patient to bite from the anteriors, if there is a posterior gap or the posterior teeth are not coming in contact, what happens is the dentures flip or they lose their stability. Okay, because there is no contact at the back and you're just putting the force on the front. So there's a lot of occlusal forces. The backside is open, so it flaps or it loses its stability. So in balanced occlusion, what you do is, even though when there is contact in the anteriors, you arrange the teeth in such a way even the posteriors come in contact. So on both sides, that is bilateral. So a simultaneous contact between in the posteriors and the anteriors of the occlusal surfaces. This is balanced occlusion. That means 3 points of contact will be there, one in the anterior and two in the posterior on the bilateral sides. Okay, this is balanced occlusion. It is developed to lessen or limit the tipping or rotating of the denture bases in relation to the supporting structures, as we thought, to limit the stability. And balanced occlusion is unique in complete dentures and are not seen in natural teeth. Remember, balanced occlusion is never seen in natural teeth. Balanced occlusion is only done in complete dentures to get the stability of the dentures when the patient is actually doing parafunctional movements. So now when you're saying parafunctional movements, what is this? See, basically when you are chewing, there is contact, right? When the patient bites, there is maximal intercuspation in the denture as well. So when chewing, there is no balanced occlusion taking place. Meaning to say there is already bite where there is contact with all the teeth, right? In complete dentures. So why do we give balanced occlusion? Only the patient actually undergoes chewing or function of mastication only for about 10 minutes in a day, 10 to probably 30 minutes in a day when he eats his food. But apart from that, he has certain movements when he's not biting where the teeth are coming in contact. Okay, that is probably when he's talking, when he is sipping, when he is actually uh, uh, swallowing his saliva and stuff. So that time there is these teeth are coming in contact. So when these functions are taking place, if the only the incisal part of the upper and the lower come in contact, the posteriors are open again, which will cause instability of the denture. So you give a balanced occlusion and is usually for parafunctional movements. Now, objectives of balanced occlusion. Why do we need to do a balanced occlusion? Improves the stability. It improves the stability and retention of the denture during parafunction and during function. Reduces the residual ridge resorption. How? That is, when there is force only acting at one spot, that portion of the ridge tends to resorb faster, and those areas where there is no occlusal forces acting, they do not resorb. So if you evenly distribute by giving balanced occlusion, evenly distribute the occlusal forces to the entire denture bearing area, then the residual ridge resorption completely reduces. To reduce the trauma and occlusal forces on the oral tissue, the same thing. What forces which are acting on the residual ridge, each the forces will also be acting on the oral tissues. So the trauma will reduce and it will be evenly distributed to improve the oral comfort at the end of the day. Okay, so this is the importance of balanced occlusion. So concepts of balanced occlusion, there were a number of concepts which were given. There are 10 concepts which were come out about each of them giving their own concepts, but the most common concept we follow today is Hanau's concept, and we also arrange our teeth according to Hanau's concept. That is basically the balanced occlusion. So Guy's concept was given, French's concept, Sears concept, Pleasure concept, Frush concept, Hanau's concept, Trapezona's concept, Lod's concepts, Boucher's, and Levin's concept. Okay, these are the 10 concepts. You do not have to know any of these concepts, just to know about Hanau's concepts, and the 5 factors what he gave is all what you got to know. Factors affecting balanced occlusion. 5 factors are there. One is inclination of condylar guidance, inclination of incisal guidance, plane of occlusion, compensating curves, and cuspal inclination. The 5 factors are now called as Hanau's squint. Hannah Squint. Yeah, Hannah Squint. So uh, there were actually 8 concepts what Hannah Squint came up. Then they remodified and he made it into 5, eliminating 3 of them. So you just have to know about this 5 factors which determine the balanced occlusion. So let's talk about each factor as we go on. First one is balanced occlusion. So we have condylar guidance. So mandibular guidance generated by the condyle and the articulating disc traversing the contour of glenoid fossa. Condylar guidance is due to the path followed by the condyle in the TMJ. That is, as I spoke, condylar guidance or the condylar angle. What you see in the figure, you see 2 green lines. One of the line is the Frankfurt horizontal line, and then we have the other line which is the gliding path of the mandible or the condyle on the glenoid fossa. So when you open your mouth, there is slight rotation and then there is gliding of the condyle over the glenoid fossa. That angle what it is making is called the condylar guidance. Now why is it important? We will speak about it as we go on in the lecture. Then we have is incisal guidance. This is nothing but the angle formed between the two surfaces of the anterior teeth. So the maxillary palatal surface, anterior teeth palatal surface, and the mandibular anterior teeth labial surface. They make an angulation. What you see as in the figure, they make an angulation. That angle is the incisal guidance angle. So the incisal guidance angle is always it's always try to get this angle is always tried to match with the condylar guidance. Why is it? Is because if you do not match, there might be instability when the patient is doing any kind of protrusive movements. So incisal guidance should always be matched with the or close to be matched with the condylar guidance. Now is plane of occlusion. So we know that plane of occlusion is it's an imaginary surface which is related anatomically to the cranium and which theoretically touches the incisal edges of the incisors and tips of the occluding surface of the posterior teeth. Okay, it is not a plane in true sense. It is not a straight plane or a straight line, okay, as by the word it says plane of occlusion, but it represents a mean curvature of the surface. As you see in the figure, you can see a small curvature which is taking place from the incisal tip to the posteriors. When you draw a line by the lateral view and the frontal view, you can see a small curvature. That is your plane of occlusion, established anteriorly by the height of the lower cuspids and posteriorly by the height of the retromolar pad. So when we spoke in the last denture, when we spoke in the last lecture, we spoke about where the plane of occlusion should be. So it is basically in the height of the lower cuspids, that is the incisal surface of the lower cuspids, which moves posteriorly to the 2/3 of the retromolar pad. Okay, so that is where the height of your plane of occlusion is. Next is compensating curves. So when we speak about compensating curves, there are certain compensating curves which we would have to remember, and why do we have to replicate this in your complete denture to produce a balanced occlusion. So compensating, there is anterior, posterior and lateral curvatures in alignment of the occluding surface and incisal edges of the artificial teeth, which are used to develop balanced occlusion. So steep condylar path requires steep compensating curves. Now condylar guidance. Now what happens is when the condylar head of the mandible is gliding over the clinoid fossa, it makes an angle and it drops down in that angle. So when that angle is done, even the mandible is actually opening and gliding down, right? So there will be a separation which is going to take place with the anterior teeth and the posterior teeth when this gliding takes place. But in complete dentures, this separation should not be there. So by giving the compensating curve, that is the curve which is seen, this is space will be closed or it will be compensated. That's why it is called compensating curves. We have curve of Wilson 1, curve of Monsoon, curve of Spee and curve of Pleasure. I know this understanding this by just me speaking over the lecture is quite difficult for you guys. As you come into clinics, please, if you do not understand any of these concepts and you want to know or you want to understand, I can probably show you how it works on a denture. So if I show you on the denture, and you by seeing this you would understand what exactly are you doing on a balanced occlusion and what are these compensating curves which are actually making this balanced occlusion happen. Okay, so feel free, approach to me and ask me and let me know, because just reading this lecture I am sure you guys would definitely not understand what I am speaking to you. Okay, it's all over your head, I can understand that, because as a dentist even I had this all over my head. But as a prosthodontist, yes, now I understand what is all this. Okay, now balanced occlusion, curve of Wilson. In theory, that occlusion should be spherical. The cusps as projected on the frontal plane expressed in both arches, the curve in the mandibular arch being concave and the one in the maxillary arch being convex curvature. So you see in the diagram you have a convex, concave and the convex curvature. The curve of Wilson also permits lateral mandibular extrusion free from posterior interferences. Okay, how does it help? Curve of Spee in occlusion. The curve of Wilson also permits lateral mandibular extrusion free from posterior interferences. Aligning both maxillary and mandibular posterior teeth with the principal direction of muscle contraction produces the greatest resistance to masticatory forces. So you give this curve of Wilson is because it is principally aligning to the contraction of muscles. The way the muscles are contracting, the same way the teeth are going to get glided inside. So that's the reason you give this curve of Wilson. The role of curve of Wilson in mastication is when the curve of Wilson gets altered, masticatory function may be impaired because increased activity is required to get the food onto the occlusion table. Okay. Now coming to curve of Spee. So this curve of Spee is the anatomical curve established by occlusal alignment of the teeth as projected onto the median plane, beginning with the cusp tip of the mandibular canine. From the cusp tip, when you draw this line, the curve, and following the buccal tips of the premolar and the molar teeth, continuing through the anterior border of the mandibular ramus and ending at the anterior aspect of the mandibular condyle. So this curve runs from the canine onto the cusp tips, onto the cusp tips of the premolars and the molars, and continues further to the anterior border of the mandibular ramus and then extends to the anterior aspect of the mandibular condyle. So why is this curve important? Is when the condyle is gliding, it gives a gliding motion to the gliding motion of the teeth, and they are always in contact. So giving this is kind of curve is important. So basically, how are you going to give this curve? Is you arrange the teeth in such a way from the canine to the posterior, that is your maxillary second or your first molar. You give a slight curve, that is your occlusion is raising. Okay, from the canine is going to be lower in occlusion, the premolar is slightly going to be upper than the canine, and the molars are going to be slightly upper and upper. So then you will eventually get the curve. So when there is a gliding of the uh, condyle, this this also helps in a slow gliding and helps in stability of the denture. Role of curve of Spee in mastication. Osborne reported that the curve of Spee had a positive correlation with the inclination of masseter muscle. This forward tilt of the mandibular posterior teeth arrangement maximizes the muscular efficiency during chewing. The next one is curve of pleasure. So the curve of pleasure, a helicoid curve of occlusion that when viewed in the frontal plane conforms to the mediolateral convex curve in which the lingual surface of the teeth are more coronal to the buccal surface. Buccal surfaces except for the last molars which reverse the pattern. It increases total efficiency, the stability of the upper denture during speech, laughter, coughing, sneezing, etc. So enhancing the stability of the lower denture during closure against a morsel of food, increased cutting efficiency because of longitudinal sliding movement of the lower cutting ridges, reduces occlusal pressure and tissue trauma. Basically, how are you getting the curve of Spee? Is basically, you know that when you arrange your posterior teeth, your maxillary posterior teeth, they're buccally tilted, and when you arrange the mandibular teeth, they are lingually tilted. So when the patient is biting, because of this tilt, the occlusal surfaces, that is the cusp of the lower, is coming into the groove of the upper. So this curve of pleasure gives this occlusal contact. Okay. Now coming to next one is curve of monsoon. Curve of monsoon is curve of occlusion in which each cusp and incisal edge touches or conforms to a segment of the surface of a sphere 8 inches in diameter, which is with its center of the region of the glabella. So if you see in the figure, if you take a if you make a sphere of 8 inches where its center is in the glabella. You see the curvature which is at the teeth. So you arrange the teeth in such a way that this curvature, it follows this curvature. Although Monson's principles were not in an ideal condition, basically this principle was given for an ideal condition patients. So later there was a seldom use of this in adult dentition. So curve of Monson is not so really important, but yes, to an extent it helps in balanced occlusion. So now Hanau's quint. So he gave a diagrammatic figure showing how each factor determines the balanced occlusion. So by increasing the inclination of the incisal guidance, you have to increase the cusp depth, that is the cusp inclination, and also increase the compensating curve, increase the plane of occlusion, and there will be a decrease in the condylar angulation or condylar guidance. The same way he explained each factor by increasing each of the factor what has to be reduced. If you see in the plane of orientation, condylar guidance increases, cusp tip decreases, and curve also decreases, and incisal angle increases. So all the 5 factors were used to determine, and also what exactly has to be done to get a balanced occlusion. So this is your balanced occlusion, and I assume, no, I don't assume, but I really know that you guys have not understand anything about balanced occlusion. Please do come across and ask me. I will explain to you with the help of the complete dentures, or anybody who's doing a try-in. Before the try-in, when you have arranged your teeth, do come across and ask me how balanced occlusion is working, or whether you have done a balanced occlusion, and then I can explain you much better. Okay, now the next one more kind of occlusion we will look at is lingualized occlusion. So lingualized occlusion can be defined as the form of denture occlusion that where the maxillary lingual cusps articulate with the mandibular occlusal surfaces in centric working and non-working mandibular positions. It is basically mean to say it is a cross bite. Okay, when you have the maxilla which is placed further inside and mandible which is further outside. It's kind of a cross bite. So next, coming to indications. Where is it indicated? Where do you use this thing? High aesthetic demands, severe mandibular ridge atrophy, and displaceable supporting tissues, malocclusions, previous successful denture with lingualized occlusion. Advantages is good aesthetics, freedom of non-anatomic teeth, and potential for bilateral balance, centralizes vertical forces, minimizes tipping forces, and facilitates bolus penetration. Okay. Errors. Next, we talk about a little bit of errors in occlusion. What are the causes for error in occlusion? Change in the state of health of TMJ, inaccurate maxillomandibular records by the dentist, errors made in transfer of maxillomandibular records to the articulator. This is also important. Once you seal your maxillary sorry, when you seal your occlusal rims, you will have to carry them exactly the way you sealed it and articulate it, because any changes after you're done the recording can lead to change in the occlusion. Sorry. Failure to sit occlusal rims correctly on the cast. Okay, and ill fitting temporary bases. If the temporary bases are not good fitting while doing the recording, they might slide and give you a different recording. Failure to use Facebook and subsequently changing the vertical relation of the articulator, and incorrect arrangement of posterior teeth, failure to close flask completely, and use of too much pressure in flasking also displaces the tooth and tends to give you an occlusal error. So next is problems due to error in occlusion. Denture instability and discomfort. These are the two problems what you see. So last lower tooth too posteriorly placed, orientation of occlusal plane not parallel to the ridge, okay, uneven in initial contact. If there is a premature contact or first contact by any of the cusp, there is going to be denture instability. Intercuspal position and centric relation does not coincide. It has to coincide. If it doesn't coincide in the denture patients, complete denture patients, then you are going to have denture instability and excessive vertical overlap of anterior teeth and lack of balanced occlusion. Discomfort is pain on eating in the presence of occlusal imbalance. So basically, when there is a premature contact, that portion of the teeth is coming in contact, so there is more forces acting on that area of the residual ridge, which will give pain on pain on eating, pain or ulceration. So there may be development of ulcerations on the labial to the lower ridge, on labial aspect of the lower ridge, lingual and labial aspect of the lower ridges, and there is pain in the at the periphery of the dentures in the depth of the sulci. So basically sulcus areas you might find pain. There might be cheek and lip biting, tongue biting, and soreness of on the crust of the ridge. So these are some of the problems what you arise when you have improper occlusion recording, or there if there are any errors in the occlusion. So this is your lecture for occlusion. I know I was a little fast, but trying to explain is quite a little difficult just by theory. So just go through your lecture, just read a little bit of your book. Deepak Nallaswamy doesn't talk that well about occlusions, though he has all the concepts and all that given. There are certain mistakes. You can use other books like Boucher's to understand a little more about balanced occlusion, and do a reading. And then when the classes do start, do come and approach me and ask me about balanced occlusion. And when you're doing your teeth arrangement, do ask us, me or Dr. Shilpa, anybody. We are very happy to help you and make you understand what exactly are we doing when we talk about balanced occlusion. Thank you and have a nice day. Stay safe and stay at home. Then methods of how do you correct when you have caused these errors of occlusion. So by remounting and selective grinding, these are the two methods you will use for correcting your occlusion: remounting and selective grinding. And after you have done once you remount it, you can use the articulating paper, or in the patient's mouth, which is selective grinding. When you're doing, put the articulating paper, see which cusp is coming into interference, and then reduce that at cusp. Then carbon papers can be used, then central bearing devices can be used, occlusal wax can be used, and abrasive pastes can be used. These are some of the devices which you can use, or papers or pastes which you can use to which helps in correcting your occlusion. The next one, we have relevant terms. Some of the terms you got to understand in occlusion to understand the chapter much better. Now occlusion, any contact between the incising and masticatory surfaces of maxillary and mandibular teeth. I have put OD by mistake, it's off instead of OD. So so any type of contact, that means to say, even if you have an incising contact, a canine contact, or even if there are minimal or subtle contact, it is called as an occlusion. It does not mean to say they have to be in maximum intercuspation, or they might have to be properly occluded. So next is your centric relation. Centric relation, we discussed about it in the last chapter. What is centric relation? Why would we need it in complete dentures? So centric relation is nothing but the relation between the maxilla and mandible when the condyle is in, or the condylar head of the mandible is in a anterior superior most position in the glenoid fossa. So if this is there, this is independent of teeth. So there might be contact with the teeth, there might not be contact with the teeth. If the condyle is in that position in the glenoid fossa, independent of tooth contact, the relation what you see between the maxilla and the mandible is centric relation. So why is this important? This is important for you to construct your, or to arrange your teeth in this relation in a complete denture. Okay, so this position is independent of tooth contact. And yeah, when we talk about opening of the mandible, so when we see that the opening is, first the mandible rotates, it rotates in a terminal hinge axis, there is a rotatory movement, and then the condyles glide over. When you further open, it glides over onto the glenoid fossa. Okay, so the first terminal hinge axis movement what you see, that movement is also centric relation. So the entire hinge axis movement is your centric relation, because in this terminal hinge axis movement, the condylar head of the mandible is still in the anterior superior position in the glenoid fossa. Okay, so it is restricted to purely rotatory movement about the terminal hinge axis or horizontal axis. Once if it opens furthermore and it starts gliding over the glenoid fossa, it is out of centric relation. So only in that rotatory movement it is considered to be a centric relation. It is anatomically determined, it is reproducible and repeatable. So when a patient loses his teeth, he does not know how he is biting, so his senses or stimuli is in the TMJ, so he is able to determine whether his mandible is in the right position with the maxilla if it is in centric relation. So he can reproduce it and he can repeat it, and you can also measure it. Okay, so this is centric relation.